nice discussion. So we go on
Yeah.
with the next candidate. Clarity in and about pediatric uveitic cataract surgery, etiology and outcome. Dr. Shivagami.
This is the last one. No?
A very good afternoon to one and all present here. I'm here to present about clarity in and about pediatric uveitic cataract, etiology and outcome. Though the prevalence of uveitic cataract is very rare, about 70% of the pediatric patients develop uveitis-related cataract over time. However, the output of the cataract surgery depends upon a lot of factors. So hence we did a retrospective analysis to evaluate the etiology and outcome of cataract surgery in children with uveitis. Coming to the materials and methods, it was a retrospective observational study conducted between January 2019 to 2023 in children less than or equal to 16 years with uveitic cataract, which was done at the Pediatric and Uvea Clinic of Arvindai Hospital, Pondicherry. We included children who were less than or equal to 16 years and who had uveitis and had undergone cataract surgery, and those who came for at least 12 months of regular follow-up. We had to exclude patients who were more than 17 years or those who underwent cataract surgery elsewhere. The data collected included the patient demographics, the etiology, the vision, intraocular pressure, anterior and posterior segment findings, the treatment, surgery, and the complications. Coming to the results, there was no disparity between the male and female children, and the mean age at diagnosis was 10.7 years, and the mean age at time of cataract surgery was 14.1 years. Among the 14 eyes of the 12 patients, 4 had bilateral uveitis and 2 had bilateral cataract. On analyzing the visual acuity, compared to the preoperative visual acuity, there was an improvement in the postoperative visual acuity. But however, in the 6-month period, we saw there was a small decline in the visual acuity, which can be attributed to the posterior capsular opacification or the pigmentation of the intraocular lens. The mean intraocular pressure preoperatively was 13.6 mm mercury and postoperatively was 15.4 mm mercury. One patient had laser PI preoperatively for secondary angle closure, and one patient developed steroid-induced glaucoma at POD 15. On analyzing the etiology, majority of them had non-granulomatous uveitis with pan-uveitis for 37% and anterior uveitis 27%. GIA accounted for 34% of the patients, followed by sarcoidosis in 25%. The mean duration of the oral steroids was 8.35 months, and preoperatively was 4.96 and postoperatively 3.39 months. Among the 2 eyes which underwent vitreoretinal surgery, the majority of the duration was given postoperatively. On analyzing the duration of the methotrexate which was given, it was given for a mean of 19.28 months, among which majority of it was postoperative. An inflammation-free period of at least 3 months was ensured, and cataract extraction with or without foldable hydrophobic acrylic lens was done. Additional procedures like intravitreal triamcinolone and posterior subtenon tricot were given to reduce the intraocular inflammation in some children. The other procedures, which included intravitreal Avastin, EDTA chelation, membranectomy, yak capsulotomy, were also done. All children underwent peripheral surgical iridectomy. The other postoperative complications were also analyzed, and the mean duration of onset of the cystoid macular edema was 2.5 months, and onset of posterior capsular opacification was 4 months. The levels of inflammation postoperatively showed a decreasing trend over the duration, but however, posterior synechiae and pigments in IOL had an increasing trend. Coming to the discussion, our study revealed that the postoperative visual outcome of most of the patients was satisfactory, and systemic immunosuppression was needed to control inflammation, and dose augmentation was required in case of flare-ups in 3 cases. All eyes underwent primary implantation of IOL except one eye which required a staged secondary procedure. So some studies which were conducted in Israel and India suggested that cataract surgery improved vision in eyes regardless of the IOL implantation or not, but posterior capsular opacification leads to more secondary procedures in the pseudophakic eyes, just like ours. And a few studies retrospectively done also suggested that immunosuppressive treatment with biologicals can improve the visual outcome in uveitis, but it does not significantly reduce the postoperative ocular complications. So we would like to recommend that systemic immunosuppression in the form of steroids and antimetabolites should be given to decrease inflammation. And it's crucial to identify complications and refer them for timely management to prevent amblyopia, and regular and long-term postoperative follow-up with systemic monitoring is essential. These are my further references. Thank you.